back up there actually. When I talked about the hemoglobin saturation curve, I forgot to teach P50. P50 is the oxygen tension which provides 50% saturation. The oxygen tension, PO2. Which provides 50% hemoglobin saturation. Under normal conditions, it is 27 millimeters of mercury. Under normal conditions, P50 is 27. So I went away. Let's draw here. This is my sigmoid shaped curve. Here's my HB sat at 50%. And I'm saying 27. So at this oxygen tension, it provides something like 50% saturation. Okay. So the question becomes, when the curve shifts, one way or the other. This is a benchmark. So it can shift that way, to the right, down and to the right, or it can shift up and to the left. If you have a shift to the right, to the red curve, the question becomes, how does P50 change? So I'm writing with the right shift, how does P50 change? Does it increase or decrease?
Decrease.
If it shifts to the right, it increases. What is P50? 27. You're saying it takes that much tension to provide 50% saturation under normal conditions. Now you shift this way. Now it takes more tension to saturate at 50. Let's remember what the right word shift means. It means it favors O2 unloading. Okay, that's when I gave the analogy, the chair is slanted, you slide off easier. So, if the whole curve shifts, P50 increases. It takes more oxygen to saturate at 50% if you favor unloading. That's the concept you gotta get straight in your head. Don't just memorize it increases. You'll misremember it and you can't find it in your notes. Let me ask the inverse question. I won't write it on the board. You should get the idea now. We'll say it shifts the other way. Now the chair is like, favors binding. The chair's like that. How does P50 change? Does it increase or decrease? Decrease. Now it takes less oxygen to saturate at 50%. Whatever this is. Okay, that's the point. P50 is just kind of a benchmark in medicine. I didn't want you to know that. I taught it basically, but I didn't mention P50. So that'll come up on your test. That's why I wanted to mention it. The other thing is I'll be sure I get out, erase this down. I talked about sea level. One of the first things I drew on the board, I drew man, woman underneath an atmosphere of air. And what's the number? What's atmospheric pressure? 760. Very good. But that's basically sea level. What if you go up to, I don't know, Denver or something? Now you have less air pushing down on top of you. What happens to atmospheric pressure? Does it increase or decrease? It decreases. Now you have less air on top of you. The air is thinner, as they say. I don't know, maybe it's just concept. I don't know for sure. Don't go on your phone and say I'm wrong. Maybe it's 750. I don't know. But that's the idea. It decreases. I mean, you could go down below sea level. Like Death Valley. I think the elevation is like minus 87. I can't remember. I just don't write that down. I don't remember. The point is, you're below sea level. Okay? So the idea is, now you have more air on top of you. What happens to atmospheric pressure in Death Valley? It increases, so maybe it's like 770. Okay. Now, I didn't expressly state that, but I wanted to mention it. It does come up on your test. When you're at elevation, people usually say altitude. When you're at altitude, and students always say, was it high altitude or low altitude? Those terms aren't used. You don't say low altitude. People usually just say sea level. Okay. And they don't say high altitude, they just say altitude. So that might come up on your test too. So keep that in mind, and I'm going to move on. Close the door in respiratory. Move on to the next chapter, which is on the schedule, right on schedule, digestion. As far as I can today, and leave enough time for our spirometry lab. As you can see, you got all the stuff out. Yes, number 7. Getting to the end here. One second here. Oh, there you go.
Here, it's right here. 31st. Tuesday.
All right. Here we go. So this material for lecture exam 7 is previously stated. It still doesn't work. All right, so the goal of digestion, it's all about eating. Everyone knows about eating. And the digestive system is basically going to provide nourishment, okay? Now, as soon as you swallow that mouthful of food, you don't think about it, do you? Everything's automatic, and we're going to learn all about it. Everything that happens on the inside of your body after you swallow the food. Swallowing is pretty much the only voluntary thing of the whole digestive process, chewing and swallowing. Food is often ingested in a chemical form that the small intestine cannot absorb. To facilitate absorption, the GI tract digests food by mechanical and chemical processes shown here. So let me define these major processes, and we have a nice picture to accompany it. Give me an overview here. Ingestion is basically stick it in your mouth. Okay, insert into oral cavity. Insert food into oral cavity. There are a couple places where you have mechanical digestion. You just pummel the food, you just break it into parts. Mechanical. Well, it starts with the mouth, right? The oral cavity. Chewing. The anatomy word for chewing is mastication. Because in your mouth you got the chompers, your teeth. Chompers. And you add saliva, it helps. Well, the result of chewing is a bolus of food. The thing you swallow. Okay. And mechanical digestion also occurs in the stomach. When it reaches your esophagus, the stomach has 3 muscle layers. And basically the stomach churning accomplishes more of the fragmentation. I mentioned it's got 3 muscle layers. Everywhere else, the digestive tract has 2 muscle layers. If you look at the digestive tract, it's often described as a gastrointestinal tract from mouth to anus, just tube through your body. A gastrointestinal tract from mouth to anus. Okay, so you mean you swallow the food, it gets to your stomach. That's pretty much, stomach and mouth is for mechanical digestion. You just pummel the food. Now, chemical digestion is a truer form of digestion. Chemical digestion will get the molecules small enough for absorption. Okay, but you know, chemical digestion. Again, a lot of that happens in the stomach. tell. The acidity of the stomach can get down to 1 or 2. That acidity will break things up chemically, and it also helps prevent your intestine from becoming infected by bacteria. It's a nice chemical barrier. Okay. Breaks up food. Prevents bacterial infection of intestines. Now, the stomach also secretes a chemical called pepsinogen. Pepsinogen, I'll talk about it. Remember the type of bonds that link amino acids together in proteins? We call them peptide bonds. Pepsinogen breaks the peptide bonds and helps digest proteins. So that's a form of chemical digestion, also in the stomach. The first part of the small intestine after the stomach is duodenum. And I would say that's the chief place you get chemical digestion. Because in the duodenum, basically what you've got, it's receiving the digestive juices from liver and pancreas. I'll say receive secretions of liver / pancreas. I'll tell you what those secretions are when I get to them. The idea of the liver and pancreas, they're called accessory organs to digestion. Accessory organs. And accessory organs isn't in the tract, but it secretes things into it. Okay? Here's the tract. Liver, pancreas, they're around here. They secrete things into it, but they're not on the tract. That's why you have all these acid drops here. You're accomplishing a lot. Okay. Chemical digestion further occurs through the length of the intestine, which is about 21 feet, in the form of brush border enzymes. So I'm going to continue chemical digestion up here. These will be located in the mucosa of the small intestine. Brush border enzymes. I don't know if you remember, but the epithelium of the columnar cells that presents a microvilli brush border, and those enzymes are in there. It's like it's finishing off the chemical digestion, allowing for absorption. Chemical digestion. And absorption is the next function I want to define. It is what it is. You absorb the food into the bloodstream or the lymphatics, that's shown here. It occurs primarily in the intestines. Of food molecules into intestinal capillaries as well as lymphatics. fat globules are usually too big to navigate through blood capillary walls, but they can usually get into the lymphatics. There's a structure in the small intestine called the lacteal, colored green are our lungs. Look for that. And then what it can't be absorbed, like fibers, other indigestibles, ends up in rectum anus. Okay. Basically, the rectum is a holding chamber for feces. And then, well, when you have to go, basically you distend the rectal wall, and the reflex is to contract, and it pushes it towards the anal canal. Distend rectal wall. The reflex makes you contract. Push feces toward the anal canal. Now the anal canal, I mean, that's when you feel like you have to go. You have an external anal sphincter, which is under voluntary control. You know, that's kind of like you holding it in to get to the bathroom. The external anal sphincter, basically helps you hold it in. Helps keep anal orifice closed. It's funny, yesterday I was watching Jerry Seinfeld. He's talking about, man, the anus, it's like the lowest rung of the ladder. It's like it's at the bottom. This is my job. This is my whole life. I gotta hold this stuff in. You know, it kind of personified me as funny. That's it. But it's very important. I mean, it kind of has a social responsibility, right? You hold it in, you get to the bathroom, you make life manageable for the rest of us. Okay, so that's an overview of the whole thing. Now, we're going to talk about a lot more details than that. One thing is the GI tract structure. If you cut this GI tract in any location, we're going to look at it in our histology, but you should be able to tell where you are. And when we study histology, we're going to study 4 locations. We're going to look at a cross-sectional view. We're going to look at the wall of the esophagus, of the stomach, of the intestine in 3 locations: duodenum, jejunum, ileum. And we're going to look at the colon. Okay? And you should be able to tell where we are in the GI tract based on the appearance of the GI tract wall. However, all of those 4 locations, esophagus, stomach, small intestine, large intestine, have a same general pattern. Okay, so let's kind of go over that general pattern of the GI tract shown here. This general pattern of GI tract wall. So what I'm showing you here is the different layers. Let's go from inside to outside. Now on the inside you got the lumen. The lumen, food's passing through the lumen. forgot to define one word on the previous slide, peristalsis. Food can pass in one direction because of rhythmic contractions of the muscle layer called peristalsis. Food passes by via rhythmic contractions of the muscle layer. This is called peristalsis. Food moves in one direction toward anus. It moves in one direction. Towards anus. Right, so surrounding the lumen is the innermost part of the digestive tract called the mucosa. The mucosa is comprised of an epithelium, a lamina propria, and it has its own muscle layer called muscularis mucosa. Now, I can't define the epithelium. It changes throughout the digestive tract, depending on function. For example, when you swallow food, the esophagus is a stratified epithelium. Could be stratified. It's kind of stratified at the beginning and at the end, at the esophagus and at the anus, because that has a protective function. You kind of like rub off top layers, the apical layers, replaced by basal layers. A lot of the epithelium is columnar epithelium arranged into glands. You can see that a lot. Stratified, columnar, and glandular. Okay, we'll get into details of that. So note epithelium, lamina propria. And note the muscle layer, muscularis mucosa. You don't see this in other systems. The digestive tract has, its mucosa has its own muscle layer. This increases the food agitation, which is a good thing. Outside the mucosa is a loose connective tissue area we call the submucosa, right? Submucosa. So what's in there? A lot of glands, right? I would say the glands I want you to identify are in the duodenum. They're called the Brunner's glands. Pronounced Brunner's, spelled Brunners. So they're in the duodenum, right there. They're not everywhere, but in the duodenum. They're going to help neutralize stomach acid, because remember, duodenum comes right after the stomach. What's coming out of the stomach? All that acidic chyme. You don't want to get a duodenal ulcer, so these glands secrete an alkaline fluid to neutralize acid. Neutralize acid, okay. So lots of glands you gotta know what's in there. You know, in the ileum, the end of the small intestine, you're gonna have something called MALT, mucosa-associated lymphoid tissue. Now, they kind of put it in the mucosa, right here, these little spots there. But when we look at the histology slides, I mean, it dominates the submucosa, and it kind of invades into the mucosa. So all listed under submucosa. It's called MALT, mucosa-associated lymphoid tissue. And we're going to see it primarily in ileum And we may have slides that show it in colon. That part of the tract. So those are some important things. And there's nerves in the submucosa, and they're called the submucosal plexus. An easy name to remember. Don't worry. We'll show the yellow nerves. Submucosal plexus. We'll squeeze out the bottom here. Submucosal plexus. So around the submucosa is the muscle layer that causes peristalsis. It's called muscularis externa, not to be confused with this more internal muscularis mucosa. And students do frequently all these different muscle layers. Muscularis externa, bilayered. Got 2 layers. The inner layer, the smooth muscles, are arranged circular. So call it a circular layer of muscularis externa. So I'll just list it under here and call it circular layer. And the layer outside of that, the smooth muscles are arranged longitudinally. They go with the grain of the tube, along the longitudinal axis of the tube. So it's a outer longitudinal layer. Peristalsis is you kind of like, the circular layer can squeeze. The longitudinal layer kind of like shrinks. You know, you squeeze and shrink, and like an inchworm, you just kind of push the food forward. That's peristalsis. Now the stomach has a 3rd layer. Only in the stomach. It's called the oblique layer. And that's stomach only. A 3rd layer really helps the churning of your food. Stomach is a big wine sack shaped bag. You got a sphincter on every end. It's full of food, 2 or 3 liters. And it's just mashing at food. It's like a blender. Okay, so that's the muscle layer. Muscularis externa, and know the circular longitudinal layers. And the oblique layer in the stomach. External to that is the serosa or adventitia. Either name is acceptable. If you look at it, it's basically the visceral peritoneum. Okay. It forms a mesentery. A visceral peritoneum that forms a mesentery. Mesentery is, well, they show it there. Let me kind of draw it here. Then you have like back body wall. And you have a serous membrane lining the peritoneum. It's called the parietal-peritoneum. Parietal peritoneum. But then you have digestive tract, intraperitoneal, in the body cavity. There's here's my digestive tract, right? Intra-peritoneal. The mesentery will help hold it into place. It will shoot out, it'll wrap around the digestive tract, and then root on the back body wall. So the part that's around the organ is the visceral peritoneum, also known as serosa adventitia. And the double pinching of serosa that goes to the back body wall is called mesentery. This little double thing there. Okay, so that's the serosa, and you can also see that the mesentery, it has blood supply, nerves, lymphatics. I get to the end of these slides tomorrow, and we're going to learn about the mesenteric artery and vein with the small intestine. It's the general idea. Any questions on the general pattern? There's mucosa, submucosa, muscularis externa, adventitia. Something I forgot to mention, these nerves here. For muscularis externa, add myenteric plexus. I want you to know that. Because myenteric plexus, I'll draw a little, with the submucosal plexus is a system of nerves called the enteric nervous system. The myenteric plexus with the submucosal plexus form the enteric nervous system. Or ENS for short. It's one of the nervous systems that usually is not taught at this level. We teach autonomic nervous system, somatic nervous system. There's really no need to really, but I'll at least give mention to it. So this picture shows, it's a different picture of the general pattern of the digestive tract, showing the submucosal plexus, myenteric plexus. Some books call it mini brain, right? Because it functions on its own. You just swallow your food and it does the rest. Mini brain does the rest. Your nervous system of your digestive tract is automated because of mini brain. So we have a nice model of the general pattern shown in the small intestine here. If you study it, first identify the muscle layers, all the layers, not just the muscle layers. Now here's my muscularis mucosa, it's number 9. That's kind of like the lower edge of mucosa. Okay, this happens to be of the small intestine. So the mucosa is thrown into these finger-like shaped villi. Okay, and so that's what number 1 would be. When I get to small intestine, I'll tell you what villi are. But basically, look at number 2. Remember how I said how for absorption, the small intestine will absorb all the food through intestinal capillaries and lacteal. And that's shown right there. Number 2 is the lacteal, the green thing. The blood vessel around it is the intestinal capillary. Okay. 11 is malt. Again, 9 is muscularis mucosa. If you see yellow in the submucosa, it's nerves, it's the submucosal plexus. If you see yellow in between the muscle layers, it is the myenteric plexus. So, there's the submucosa. 11 is malt. 10 is the Brunner's glands. And then this layer, the A and the B, is the bilayered muscularis externa, number 13. Or not number 13, but 12A, 12B is both muscularis externa. 12A is the intercircular layer. 12B is the longitudinal layer. So the serosa are adventitious down there. So that's a good model to study. It's got all the layers. We have other pictures. I took a picture of this one. It's a little blurry there. But they cut out an intestinal wall and they got the layers. I got a label for you here. Mucosa, submucosa, grade, and the two layers of circular longitudinal layers in the serosa. And the color of the model is pretty accurate. It's kind of what it looks like in cadaver. There's another picture of the colon. They cut out the intestinal wall so we could see the layers. Mucosa, submucosa, circular layer, longitudinal layer is reduced to a thin band called the tinea coli. I'll write that term down when we get to colon. It gives that pocketed appearance of your colon and 11 serosa, or adventitia. Some more general concepts about the digestive tract. First, let's get a grasp of mesentery, the fused double membrane wall that I just drew over there. Here's a nice picture of it. So you can have things that are intraperitoneal, right? And then the double pinching membrane is the mesentery. And then the lining of the body cavity, parietal peritoneum. The peritoneum on the organ, visceral peritoneum. Things can be inserted retroperitoneum in development. So you got intra, you got retro. And some digestive tract things are retro. What is this? Intraperitoneum, I should say intraperitoneal. Retro peritoneal. This is describing the location of the organs. If you're in the body cavity, basically you open up the ab wall and you see it, that's intraperitoneal. You're in the body cavity, basically. And the body cavity is it's the peritoneum, right? I'll just say body cavity. If you're behind, you get behind the parietal peritoneum, that's retro. So I'm writing posterior to the peritoneum. There are some mesenteries that have been named and I want you to know them. Let's kind of look at this picture to help us learn. It's a sagittal section through the whole ab cavity so you can see all the digestive viscera. So it's kind of like this. I'll draw it bigger. Here's your torso. Let's throw some organs in there. Let's see. Let's top it out with diaphragm, dome-shaped muscle. You got liver. That's the stomach right below the liver. And right below the stomach, you got the transverse mesocolon. we got small intestines. All these little cut small intestines. Draw some of those. Stomach. Transverse colon. Small intestines. Okay, so let's draw the peritoneum. I'll use blue. Lines all this stuff, holds it into place. I like to go through this because if you work with torsos, it's like you remove the organs. Oh yeah, look at that, it's fun. You put it back together. It's not how it is. It's all held in place with peritoneum. Okay. So let me start here. So I'm aligning the back body wall. I'm going to line the inside of the diaphragm. Lining the inside of the diaphragm, and I'm going to shoot down on top of the liver and go around. And the same thing on this side. I'm going to shoot down this side. Notice how when you shoot down on top of the liver, it leaves a little spot that's not covered by peritoneum. It's literally called the bare area of the liver. A spot that's not covered. Bare area. Okay. Well, anyways, let's continue on here. Around the liver, basically it's visceral peritoneum when you're on top of an organ. There's a mesentery that's going to shoot down to go around the stomach. There's a big double, I call it the fat apron. It's the greater omentum. Okay, see what we mess up there. Okay, I'm going to stop it there. I'm going to go back here, and I'm going to draw some structures. A mesentery that goes to the transverse colon. We have some retroperitoneal structures here. And there's some space there. Because you got behind the stomach, you have the pancreas. Pancreas is retroperitoneal, along with a part of the duodenum below that. Which is part of the retro. So I'm going to draw a mesentery going around there. Okay, so that fat apron, again, that's the greater omentum. Notice the greater omentum, it's between, connected to the bottom of the stomach, and it goes to the transverse colon. This little thing that shot down between liver and stomach, that's the lesser omentum. So greater, lesser omentum, and we finish this off here. that finishes it off. So you got visceral peritoneum around the small intestines. Oops, excuse me. This mesentery here that anchors the small intestines to the back body wall is simply the root of the mesentery. Okay, I think that's all of them that I want you to know. That's a good picture to study. We just drew it out. Let's look at some other pictures and make this relatable. This is, well, the picture on the right is a picture of, it's a frontal view. We see the stomach and liver in full view. Stomach, liver. We see the fat apron hanging off the greater curvature of the stomach. Okay. And I told you it goes from stomach to transverse colon. You see the transverse colon there. Advance the slide. If you lift the fat apron up, you should be able to see transverse colon underneath. So that's what they did here. Here's the fat apron. If you just lift it up, right there, there's the transverse colon, right there. Oh, I forgot to define one thing. The mesentery that anchors the transverse colon to the back body wall is the transverse mesocolon. Let me add that to the picture. This one here. More transverse mesocolon. There's a model we have in the room. I know that that's pancreas and duodenum. So this sheet coming out here connecting to the transverse colon, transverse mesocolon. What's the fat apron again? Greater colon. All right, so that's kind of the general things. We did the general pattern, we did the mesenteries, and now I just want to kind of like unpack all the details in the study guide about the digestive tract. I call it a survey of the digestive tract. We're going to start at the mouth and end at the anus, oral cavity, esophagus, stomach, duodenum, liver, pancreas, small and large intestine. The oral cavity shown here is kind of like the dental hygienist view. I'll just kind of stick to what's used for digestion. Oral cavity, or your mouth, as it's commonly known as, you can divide it into what's called, well, what we call your mouth, your oral cavity proper. Now, I kind of don't like where they indicate the oral cavity. It's pretty much the space between tongue, palate, okay? Space between tongue, palate. You do have a space between your lips and gums. That's called the oral vestibule, okay? Or it could be between the space of your cheek and gums. Oral vestibule. Your chipmunk cheeks. You can hold things in there. And space between gums and lips or cheeks. So in anatomy, the word for gums is gingiva. Lips, labia, and cheeks is buccal. Wherever we use those words. It's pretty much, this is the space where you put a mouthpiece, like protect your teeth when you play sports. As a horseshoe shape. Okay, so just know the oral cavity proper, oral vestibule, but let's talk about other things like salivary glands and teeth. Salivary glands, there's 3 that you have to know, shown here, and know their innervation. Cranial nerve 9, glossopharyngeal, and 7, facial. Salivary glands are accessory organs. They're not in the tract, but they secrete things into it. In this case, oral cavity. Accessory organs. They're basically glands with ducts. They secrete saliva into the oral cavity. And you have the parotid, the submandibular, and the sublingual salivary glands. So saliva is composed of 2 types, serous and mucus. And 3 different glands secrete various kinds of mucus or serous saliva. So you got parotid, salivary gland. I'll just write parotid. You have submandibular salivary gland. And you have sublingual. And the duct length of the glands differs, and that determines if it carries mucus or serous saliva. Okay. So the innovation was 977. The duct length of the parotid salivary gland is the longest. Compared to the other ones, the submandibular duct length is kind of medium in between. And the sublingual, it's got the shortest one, shortest ducts. Serous saliva is more watery. Mucus saliva obviously is more mucousy, and it doesn't carry well in a duct. If you're mucousy, you get kind of stuck and clogged. So the ones with the longest duct lengths carry the watery saliva the best, the serous saliva. And if you look at the epithelial cells that secrete the serous saliva, they always stain dark. Okay, so serous glands stain dark. So the parotid gland is totally serous. It stains mostly dark. It has the longest duct length. Stains dark as those cells are secreting totally serous saliva. The watery saliva will have the enzyme. Like I said, the salivary amylase, serous saliva has salivary amylase. Helps break down starch. if you chew like a mouthful of plain white rice and eventually starts to taste sweet, because you're breaking down the starches into simple sugars. So the ones that kind of stain light and dark, the middle picture there, as a medium ductway, it can kind of accommodate both serous and mucus saliva. That's the mandibular gland. Okay, the medium ductway, that's how it stains. If you know, it secretes serous and mucus saliva. The mucus has mucins, M-U-C-I-N, that help, what makes the food easy to swallow, makes it slick, so it can slide down back of your throat. Mucus is important for swallowing. So the shortest ones, which stain light, they're just totally mucus. Saliva. And that's the sublingual. So you can identify the gland if I show you the histology based on light dark. You notice what it is. It's totally dark, longest duct length, carotid, and so forth. The other things that help you chew are your teeth and the muscles that close your jaw. We'll talk about teeth in a second, but the muscles of mastication, there's more than just these two, but I'll just have you know two. Okay. The temporalis and masseter helps you chew. Important for digestion. Two muscles of mastication. No, temporalis, masseter. They're innervated by cranial nerve 5, the mandibular division. That's the third division. I'll just put V3. That's the innervation. Here's a picture of V3. If you look at the trigeminal nerve, it's got 3 branches, the third division. Right here. So it has all these branches to different things. It's even going to go in the jaw and supply nervous innervation to your teeth. Let's talk about the teeth, your chompers. Chewing does you no good unless you have healthy teeth. In adults, I'll talk about the adult mouth. You got 32 permanent teeth. You got maxillary teeth, you got mandibular teeth, and you can see the nervous innervation. V2, V3. 32 permanent teeth. It's basically 16 of the maxillary mandibular teeth. Maxillary and mandibular. Think of teeth as a set of 8, okay, and they're labeled there. Sets of 8, basically 4 sets of 8, right? So teeth are kind of described, named on their appearance and function, like incisors. You got 2 incisors, and therefore cutting and tearing, not chewing so much. You have 1 cone-shaped canine, your fangs, cone-shaped. and you have 2 premolars and 3 molars. The premolars sometimes are referred to as the bicuspids. In teeth, a cusp is a cutting surface of the teeth. You have 3 molars, or the tricuspids. So that's your set of 8, okay? And know that the maxillary is innervated by the 2nd division of trigeminal nerve, V2, and mandibular is V3. So I just gave you a picture of V2 and V3 in this one. The maxillary division has many fibers that go to the maxillary bone here, and some go down to the teeth. So that's the 2nd division, that's the 3rd division in that picture. Just to give you a sense of that cranial nerve there. Here's a picture of, well, it's showing you the sides, 4 sides of a tooth. Mesial, distal, palatal, or buccal or labial. Find those. So they kind of have like this. And so when they have this side being mesial, that's the side of the tooth that's kind of closer to the midline. So mesial distal is basically side opposite. Mesial and distal, I mean, those are the surfaces that contact other teeth, right? But the sides that don't, the side that faces the inside part of your mouth is called the palatal part. That's where your palate is. Palatal, or the other side. Well, it depends if it's in the front. If it's in the front, it's the labial side. If it's in the back, it's next to your cheek, it's the buccal side. So this side opposite is either labial or buccal. The coating of the teeth, actually, let's talk about when they erupt. The deciduous teeth are the baby teeth, and I'm not really concerned about those. But they do show, if you're curious, you can just look. They show you when they erupt and when they shed. You know, around 1st grade, 6th grade, they come out, and then new teeth come in. Eruption, that means they are erupting above the gum line. You can see them after the baby teeth fall out. So front teeth come out first. This is like age in years. Okay, the molars come out last. There's the premolars, age 11 and 12. And then the last one to come in, your 3rd molar, teenage years or even your early 20s. The 3rd molar is called, your wisdom teeth. And a lot of people, your jaw isn't big enough to accommodate the 3rd molar. So you would have them extracted, okay, before they cause a problem, before they impact the molar in front of it. And here's how you code the teeth. You just count them. 1 to 32. 1, all the way. 16, drop down to 17. All the way to 32. So like for me, I've had all 4 of my wisdom teeth removed. So I'm just missing 1 and 32, 16 and 17. So you don't renumber them. You just skip over the space where the teeth was. So for me, you just go 2 to 15 and drop down to 18, right? 1 to 32. Okay. If you look at the structure of a tooth, kind of look at the tissues, and this is a tooth and a tooth socket. part of the tooth that you can see in your mouth is the part that's above the gum line, and that's the crown. Tooth structure. Got the crown. Erupted above gingiva. Now the part that's kind of at the same level as gingiva is the neck. That's kind of where you floss. At gum's border. Now the part of the tooth that's rooted in the alveolar bone, we simply call the root. Tooth is rooted in the alveolar socket. It's bolted in. There's these, I would note, the periodontal ligaments that bolt the tooth in the alveolar bone. Okay. Periodontal ligaments. Rooted in alveolar socket. Yes?
Is that at the end of gingiva?
Yeah, E pluralizes it. Gingiva, E. Yeah. So I'm writing bolted in by periodontal ligament. That bolted condition is classified as a gomphoses joint. A gomphoses joint. Okay, so that's the root. You're in alveolar bone. So the different tissues of the tooth, let's go inside out. For the innermost layer, you have this kind of soft tissue. It's called the pulp chamber. It's soft tissue. It's actually the same tissue as the dentin, the hard tooth. It's how the dentin was derived from it. But it remains soft. Basically in there you got the nerve, blood supply, soft tissue. Now the pulp chamber leads to a canal down the bottom of the alveolar bone. Leads to root canal. The space around the pulp chamber is hard tissue. The majority of the tooth is the dentin, as the picture shows. Dentin, it's basically bone tissue, but it's even harder. Bone tissue ossifies, it's something like 50% inorganic matrix of calcium phosphate, but dentin is more like 70% mineralized. 70% mineralized. It's hard tissue. Now, surrounding the dentin in the root is cementum. It's a very thin layer. There's the term. It's lining tooth in the root, outside the dentin. Cementum. It's more similar to bone. It's closer to 50% mineralized. Lines root of tooth. Now the hardest tissue in the whole body is the enamel that lines primarily the crown.
enamel lines the crown over the dentin. It's about 96% mineralized. Lines, crown. All right, so that's your teeth. Of course, a very common problem. There's over 220 million cases of cavities every year. I haven't had a cavity since I was 5. I got good teeth, yay. Just brush your teeth and floss, that's all I do. I think there's some genetics there. Now, cavity is basically you dissolve away, the enamel gets into the dentin. If that thing gets down into the pulp chamber, that can cause problems. The pulp chamber is soft tissue, it can become infected. You can have an abscess right there. And abscesses are basically the #1 cause of toothache. Okay? So if it gets infected, you can talk to your dentist. You can either save the tooth and get a root canal procedure. That's a procedure where they basically drill all of this away, most of the crown, and they basically file the infected canal. Okay, they stick a file in there, just root canal, and just get it all out of there. But you leave the blood supply. You get rid of the nerve, that takes away your toothache, right? You've probably been suffering for the past couple of days waiting for an appointment. But you don't need the nerve. You just need to leave the blood supply intact. Then you'd want to cap it. Okay, and if the tooth isn't worth saving, just do that extraction. All right. That's enough with teeth. So when you swallow food, the whole point of chewing is to swallow. And I got a nice picture of swallowing. It's a barium swallow, and drinking fluids there. Look at the soft palate, how much it moves. You can see the hyoid bone and the larynx. You can see the teeth in the alveolar bone. There's a frontal view. And they're able to follow it all the way down to the stomach. That's what we're going to talk about next. Okay, I think that's enough. The pictures of swallowing are not so fun to look at, but you can look up barium swallow. They're kind of interesting to see. Okay, go back to this view. Esophagus. I'll turn the lights back on. The esophagus is posterior to the trachea. It's in the mediastinum, and it's a straight shot to the stomach. There is no digestion in the esophagus. It's just a transport tube. Get into the stomach. So when you swallow it, you're in the esophagus. The name of the body cavity in the thoracic cavity is a space called the mediastinum.
thoracic cavity, thorax. When the esophagus goes through the esophageal hiatus in the diaphragm, it's immediately emptying into the stomach. We'll talk about esophagus more of its histology, not really. Doesn't do much besides peristalsis. There's a picture of peristalsis and segmentation now. Peristalsis, like I said, it just pushes food forward with those rhythmic contractions of the muscle layer. But you could also have segmentation, which mixes the food. Okay, that's what's shown in the bottom there. But peristalsis is for the esophagus. When it gets through the esophageal hiatus on the top, this gastroesophageal sphincter opens and you're in the stomach. Okay. Stomach is in the abdominal cavity. And let's kind of look at the abdominal cavity now, since we're in a different body part. The abdominal cavity doesn't have a rib cage around it. Okay, with the bones. If you add the muscles, you have the posterior abdominal wall. Okay, those are usually taught in 430. You don't have to know them for this class. Quadratus laborum, psoas major and minor iliacus, the muscles behind there. But what you do need to know is the artery in the abdominal cavity. So let's add the artery to the picture. That's the abdominal aorta. So stomach located in abdominal cavity. Abdominal cavity, no, abdominal aorta. Remember, that runs from the level of about T12 to L4 vertebra. And notice how the abdominal aorta, it's a little bit on the left of the vertebral column. I'll just put left to remind you of that. A little bit on the left side. It bifurcates into the common iliac arteries at about the level of L4. Let's add the vein to the picture. The inferior vena cava, shown here, it forms when the common iliac veins form at about the level of L5, just a little bit lower. It runs all the way up to T8. So we usually describe arteries in the way that blood flows through it, right? Blood will be flowing down the abdominal aorta, T12 to L4, but blood is flowing up the inferior vena cava. Inferior vena cava. On the right. And it forms at the level of L5, goes all the way up to T8. So it's longer, only because it's opening, the cable opening in the diaphragm is higher up. That's the only reason why it's longer. So that's basically what your ab cavity looks like emptied out. Those structures are retroperitoneal. You see the kidney there, it's all retro. So throwing all the intraperitoneal stuff, the viscera. Remember, viscera means content, see them all there. When you open up the ab cavity, you see the big fat apron. Greater momentum, you see the transverse colon, a little hammock. Right on top of it is the stomach and a little bit of the left lobe of the liver. That's basically what you see. So you don't see much of the stomach when you open the ab cavity, but let's talk about it. It's a nice blender for us. It can be a nice reservoir, hold your food, just pummel it. It's very distensible, it can hold a few liters of food. A newborn stomach can only hold about 30 ml. Okay, so over time it gets bigger. The chemical digestion that's accomplished is very effective. Again, if you get down to a pH of like 1, that's low enough to dissolve many of us. So this is the picture we looked at. You open up the cavity, can't see much. You have to completely remove the ab cavity to see a full view of the stomach with the liver kind of retracted back. if you take a peek behind the stomach, we have the pancreas. Okay, so I'm going to put that there as a note. Pancreas is behind the stomach. Let's get back to the pancreas, excuse me, let's get back to the stomach. If you remove the stomach, you have to cut in 2 locations. You have to cut the part where it connects to the esophagus, here, and then cut this part here after the pylorus. Basically, that removes the stomach from the GI tract. And you have to, of course, remove all these other things that are attached to it. Lesser omentum, greater omentum. The next slide, we have the stomach in isolation. The stomach has regions, shown here. That's a pretty accurate color of the stomach. The outermost layer, remember, is the serosa. That's kind of the color of it. So there's the esophagus. The first part of the stomach, they call it the cardia because it's close to your heart. Let's remember where we are. We're right under the diaphragm. And what sits right on top of the diaphragm? The heart. The apex of the heart is. So they always say, a way to a man's heart is through his stomach. It's literally true. I think it's meant figuratively, but it's literally right next to the heart. So, regions of the stomach. Cardia. This is basically the part where you're receiving food from the esophagus. Receive bolus of food from esophagus. The superior round part is called fundus. The fundus is kind of like when you drink carbonated beverage. All the carbonation kind of rises up to the fundus. I'll just say it collects CO2 from a fizzy beverage. It's the superior round part anatomically. Now, the majority of the stomach is the body. Okay. Majority. Now, you can see that the shape of the stomach, it kind of narrows to a funnel. That funnel is called pylorus. Pylorus is a word that means gatekeeper, because this is going to guard the stomach acid from entering the duodenum. The physical gatekeeper is a structure called the pyloric sphincter. It's a very strong sphincter inside there. The kind of knobby looking appearance right there. That's where the pyloric sphincter would be located to protect the duodenum. Pyloric sphincter guards the duodenum from stomach acid. So you got the regions, you have these nice curvatures. The lesser and greater curvatures are named for their attachment to lesser and greater omentum.
lesser slash greater curvatures of the stomach are named after their attachments to lesser or greater omentum. Named for their attachment to lesser and greater omentum. So the anatomy is not so hard of the stomach. But let's look at the layers. You're looking at the serosa, the outermost layer. If you remove the serosa and look at the 3 layers of muscularis externa we pictured here, leave an illustrated endoscope. You do that if you suspect you have an ulcer, a stomach ulcer, which can happen because of all the acid that's always secreted. Okay. 3 layers of muscularis externa. Remember, it's the innermost one is circular than longitudinal, but this one, there's even an inside layer called the oblique layer. So the innermost layer is oblique layer. Then you have a circular layer, and you have longitudinal. Layer. Here's a picture showing you the internal appearance of the stomach mucosa from the inside. If you look at the picture on the right, notice that the folding, the stomach foldings of the mucosa, they're called rugae, and they're kind of longitudinal. Longitudinal folds of stomach mucosa are called rugae, with a D on the end. Basically, food sloshes back and forth as the stomach churns. Here's the pyloric sphincter shown right there. Normally that's like sphincters pucker, they keep it shut. Okay. Now when you digest food and move it to the duodenum, these waves wash the food down, and only a few mils will kind of squirt past the gatekeeper, which is allowable. Okay, you can handle a few mils at a time. The duodenum can, so you don't have too much acid in the duodenum. You might have a duodenal ulcer. Here's a picture of a model of our stomach. And it does a good job showing all the layers. You can see the rugal folds, the rugae, right there. There's a pyloric sphincter. That's the coloration of the serosa. It's hard to see, but there's fibers running in this orientation. If you're running lengthwise there, you're a longitudinal layer. The circular layer shown there, and that's the innermost oblique layer shown there. Okay. So there's propulsion of the food, and with each wave of muscle contraction, you're going to wash just a few mils and get past the gatekeeper. That's really all I want you to see there. Okay. You just kind of send a little bit along at a time. So when you're literally full, you got to slow down because you can't push too much past the sphincter. If you overeat, you'll just get sick and vomit. The gastric secretion is very important for the stomach, and we spend a lot of time talking about it, and it occurs in 3 phases. However, I think this is a good spot for a break. Come back in 20 minutes, and we're going to start our lab, so be ready for that.